All right, I have 12 o'clock, so we'll go ahead and get started. I want to welcome everyone to Medical Grand Rounds at the University of Colorado. It's my pleasure today to introduce our guest speaker, Dr. Stephanie Mueller. But before I do that, I just want to have a few announcements. The first is please see the chat message to claim your CME and or mock credits, which are available for all Medical Grand Rounds this year. Second, please remember to use the Q&A feature to ask questions of Dr. Mueller. Myself and the chief medical residents will gather those questions and we'll save them for conversation at the end of the talk, but you can put them in anytime throughout the talk. And then the last announcement I want to make is that nominations for Medical Grand Rounds for AY 22-23 are open now. So please let us know if you have speakers you'd like to see for Medical Grand Rounds. They can be internal to our divisions and departments. They can be external. You can submit them independently through the Department of Medicine webpage, or you can send them to your division head for divisional nominations. But please let us know in the next 2 to 3 weeks who you'd like to see speaking in the next academic year. And now it is my pleasure to welcome today's Medical Grand Round speaker, Dr. Stephanie Mueller. Dr. Mueller did her medical school training at UMass Medical School. She is an intern, a resident, and a chief medical resident at Beth Israel Deaconess in Boston. She followed up her residency training with a GIM fellowship at Brigham and Women's Hospital and also received her MPH with a concentration in clinical effectiveness from the Harvard School of Public Health. She has been a leader in general internal medicine and hospital medicine in the Harvard system and is currently an assistant professor of medicine at the Harvard Medical School. Following her training, Dr. Mueller has truly become a national leader in patient safety and patient safety research. She was a co-investigator in the IQ MAPLE study, looking at maintaining accurate problem lists in the EHR. She was one of the disseminators and early developers of the iPass handoff tool that many of us are very familiar with. She was a co-investigator on the Marquis 2 trial, looking at dissemination of medicine reconciliation tools. And her work has been funded by a KO8 award looking at safety and quality of interhospital transfers. And she is, in addition, currently a PI on an internal CRICO-funded effort to improve those efforts within the Harvard system. Her work has led to over 30 publications, a number of national leadership positions, and almost too numerous to count speaking invitations as other institutions are trying to replicate what Dr. Mueller and her team have done in Boston. For these and other efforts in 2017, Dr. Mueller received the Society of Hospital Medicine's Junior Investigator Award. In addition to her funded research, Dr. Mueller is a champion of many things in medicine. One of those is a champion of women in medicine. She's focused much of her time and effort on improving mentoring and research opportunities within hospital medicine for women and for others in her discipline. She's a dedicated teacher, having been recognized for efforts at all levels of medical education. She's a frequent speaker, as I said, nationally and internationally, and it truly is an honor today to welcome Dr. Stephanie Mueller to our Medical Grand Rounds.
Great, thank you so much for that that wonderful introduction, and thank you all for having me today. It's really, I have so many sort of friends and colleagues that are at your institution. Would love to see you all in person, hopefully sometime soon. But in the meantime, I'm very happy to be with you in the virtual format today, talking about my work on improving the quality and safety of interhospital transfers. So, before we get started, for conflicts of interest, I do receive some research funding from Boston Scientific, but the funding has no relation to the work that I'm going to be presenting to you today. So here's the learning objectives that I'm hoping to go through today. So first, I'd like to just start with reviewing some of the foundational data that we've been doing on interhospital transfers sort of on a national scale. And then I'd like to move into identifying aspects of interhospital transfer that contribute to quality and safety risks. And then lastly, I'd like to focus on sort of how we can use all of this information to move on to our next steps to really try to improve the quality and safety of this care transition. So to get us started, I wanted to start off with a case. And I think it's always important kind of with whatever research that we're doing or whatever our focus is to start off with a case, because for me, this is sort of what grounds us in terms of why we should care about what we're talking about. So in this case, this sort of highlights why we should care about interhospital transfer patients. And this is a real case that was presented at our residency morbidity and mortality conference. And this was one of my first years on faculty, and I was kind of peripherally involved in this case as I was the assigned attending for this patient, although I never ended up actually meeting this patient. So this was a page that was received by our night float resident at 9 p.m. And the page said, "Miss S has arrived. She's confused. Please come to assess." So the admitting resident had had no prior knowledge of this patient's pending arrival from the outside hospital. And she did a quick check of our electronic health record, and the patient had no prior records at our hospital at Brigham and Women's. She went to perform a bedside evaluation and found that the patient was afebrile, had a heart rate of 89, blood pressure was a little bit low at 100/50, slightly elevated respiratory rate at 25, and she was satting 96% on room air. The patient was an elderly woman who was lying in bed. The patient was visibly confused, calling out to people that weren't there, and was oriented only to herself. She had some abdominal tenderness on exam, but otherwise her exam was overall pretty benign. So the resident reviewed the transfer records that came with the patient. And at this time, all the records came as paper format. And what she found was a report of a chest x-ray that had been done 2 days prior, a report of an abdominal ultrasound that was also done from 2 days prior, and copies of several brief progress notes, but there was no notation of the patient's baseline mental status. And importantly, there was no transfer summary that documented her 5-day hospital course prior to the transfer. So the resident sent stat labs that was notable for profound hyponatremia, as well as an anion gap acidosis. She performed an ABG that confirmed that she was acidemic. The patient became more hypotensive, that ultimately was non-responsive to multiple IV fluid boluses over the course of the night. And she was ultimately transferred to the intensive care unit in the early morning hours. Hence, I never met the patient, even though she was initially assigned to me. The patient unfortunately died several days later from overwhelming sepsis that was presumed secondary to bowel ischemia. So let's take a step back and just review this case. The patient was ill on arrival. She was tachypnic. She had a borderline low blood pressure, although again, there was no known baseline at the time of her initial evaluation. The patient had new confusion, although again, that wasn't clear at the time of her initial evaluation. There was a lack of clinical information that was available to the admitting physician. There was no expect note in our electronic health record. There's no transfer summary that accompanied the patient. She had sort of scattered medical records that accompanied her. The patient arrived on off hours, so the admitting resident was unable to contact the transferring provider to obtain more information. So let's use this as a launching point into sort of our first overall learning objective, some of the foundational information. What do we know about inter-hospital transfer? Well, we know that inter-hospital transfer is one type of hospital-based care transition. And transition in care can be defined as the movement of a patient from one setting of care or provider of care to another. Now, we know that care transitions are vulnerable times for patients, and particularly in the hospital-based setting. Data shows us that poor communication during transitions in care has been associated with worse patient outcomes, including adverse events, delayed diagnoses, redundant tests, longer length of stay. Now, most of this data is on intra-hospital patient handoffs, but presumably these risks of care discontinuity are even greater for patients that are undergoing inter-hospital transfer, as this tends to be a really sick group of patients. And there's a lack of system factors in place, such as shared electronic health record or shared personnel, that might help to fill in these gaps in communication. But despite these risks, there's really not that much known about inter-hospital transfer. So when this case was presented as an M&M, I started looking into the literature just to see sort of what was out there about inter-hospital transfer. And what I found was that there was a lot of data that came out about hospital transfers back in the 1980s. And this is really mainly related to the patient dumping phenomenon. And that ultimately led to the passage of the EMTALA laws in 1986. There was more recent data, this was about 10 years ago, so this was in the early 2000s, there was more recent data that focused on specific patient populations, such as ICU to ICU transfers, although a lot of that was really related to kind of the equipment that you needed for the physical transfer of ICU patients. And there was also some data about the transfer of acute MI patients to hospitals that had revascularization capabilities. But there really wasn't a whole lot of modern data looking at inter-hospital transfers on a national scale with sort of a more diverse group of patients like we see on medicine. So I took Julie Andrews' advice and I wanted to start at the beginning. So when I started this research, what I really wanted to get a sense of was some of these basic kind of foundational questions about inter-hospital transfer. How common is hospital transfer, especially across a diverse group of patients nationally? What are the characteristics of transferred patients, and how do transfer practices vary between hospitals? So to get into that sort of first foundational set of questions, I did this study that was focused on the Medicare population. So I used Medicare data, and that included Medicare beneficiaries, so age greater than 65, nationally represented Medicare data that had an acute care hospitalization in the year of data that we had access to. And the outcomes that we wanted to look at were frequency of interhospital transfer, characteristics of transfer patients, and variability in transfer practices. So again, some of those foundational questions across a more diverse and nationally representative group of patients. And we importantly linked the Medicare data with AHA or American Hospital Association data, so we were able to get both patient and hospital characteristics. So jumping into the results of this sort of first foundational set of questions, first looking at the overall frequency of hospital transfer, what we found was from approximately 7 million included beneficiaries, a little over 100,000 or 1.5% of these Medicare patients underwent interhospital transfer, again, across a whole variety of diagnoses. Now, as I mentioned, we know from other recent data that transfer is more common among certain patient populations. So as these studies show us, about 1 in 20 or about 5% of Medicare patients that are admitted to the ICU will undergo hospital transfer. And actually up to 50% of Medicare patients that are admitted with acute myocardial infarction to non-revascularization hospitals will undergo interhospital transfer. Now, one thing I just want to pause here and mention as I start going through these data is you can see the year of this publication was in 2017. So fairly recent, within the past 5 years. But, as we all know, our world has changed a lot over the past 5 years, and especially the past couple of years. And I think, with the onset of COVID, certainly anecdotally, what we've dealt with at Brigham and within sort of the Mass General Brigham system, and from reports of what we heard at other hospitals, I think hospitals' approach to interhospital transfer in particular, among other things, has changed in light of the pandemic. So to try to quantify this in some way, I've been fortunate enough to work with the Home Run Collaborative Group over the past couple of years. And the Home Run group has sent a survey to participating hospitals on their response to COVID across a kind of whole variety of topics. But included in this survey was asking sites how they approach their management of interhospital transfers. And so as we can see here from these results, that over 50% of hospitals reported that their approach to interhospital transfer has changed in some manner, either how they accept patients or how they manage their interhospital transfers has changed in light of the pandemic. So I think it's important to consider that although our work and the work that I'm going to present to you today on this topic is pretty recent, and I think an important contribution to this literature, we know that transfer practices are dynamic, particularly in modern day and in response to the COVID pandemic. And so we have to keep that in mind as we continue to interpret the data that I'm going to show you, and also particularly as we move to the next steps. So going back to this study, we next looked at characteristics of transferred patients. And I think unsurprisingly, we found that these patients are sick, right? And this is sort of what we would expect, that sick patients are the ones that undergo transfer. So compared to their non-transferred counterparts, transfer patients have a higher HCC risk score. That's a comorbidity risk score that's used for Medicare data. They also have really high rates of the top comorbid conditions that we see frequently in hospitalized patients. So CHF, renal failure, arrhythmia, COPD, as just several examples. So lastly, we wanted to look at variability in interhospital transfer, or the between hospital differences in transfer rates. So to orient you on how we did this, on the y-axis, you can see the hospital transfer rates. And on the x-axis was the 3 different models that we ran. So the first model was the unadjusted model. The second model, we adjusted for patient characteristics. And then the third model, we adjusted for both patient and hospital characteristics. And what you can see is that sort of this yellowish orange boxes indicate the transfer rates between the 25th and the 75th percentile. And then the whiskers extend down to the 2.5th to the 97.5th percentiles. So what we can see is that as we go through the models, once we reach that final model of adjusting for patient and hospital characteristics, the variability in hospital transfer rates, the between hospital transfer rates, diminishes a lot. So this tells us that hospital characteristics account for most of the observed variability that we see in hospital transfer rates. And that's not surprising, right? Because if a patient presents initially to kind of a smaller rural hospital, they're more likely to undergo transfer compared to patients that that might, initially present to a larger tertiary care facility. But what we also see is there's still this residual unexplained variability in hospital transfer rates, even after we accounted for all the patient and the hospital characteristics. And that is suggestive of potentially non-standard transfer practices. So that's supported by other sort of recent data that's out there. This was a study that was conducted where they examined 32 transfer centers at large tertiary care hospitals and ultimately found marked variability in both the personnel that staffed those transfer centers and the practices in terms of how these transfer centers managed interhospital transfers. So in summary, this kind of first piece of foundational evaluation of interhospital transfers, we found that a sizable number of patients undergo interhospital transfer. So a little over 100,000 Medicare patients per year, or about 1.5% of the Medicare patients that we looked at, with, as I mentioned, greater frequency in select patient populations. But with a caveat that this might be a different picture in this sort of post-COVID era that we live in now. We also found that transfer patients have really high rates of comorbid conditions. And we found that there is still this unexplained variability in hospital transfer rates, even after we account for both hospital and patient characteristics that might be suggestive of non-standard practices that's supported by other literature that's out there. So next, we wanted to jump into evaluating the outcomes of transferred versus non-transferred patients. And the specific outcomes that we wanted to look at were length of stay and cost, which we sort of grouped together because those are very interrelated, as well as 3 and 30-day mortality. Now, the tricky thing about this is that we wanted to adjust as able for this concept of confounding by indication. So I just went through all this data that showed that transferred patients are different, right, than the non-transferred patients. Transferred patients are a sick group of patients. So how do we adjust for this in looking at these outcomes? Well, we did this in 2 ways. So the first way we did this is we limited our analyses to the top 15 primary diagnoses. And then we stratified all of our analyses by the primary diagnosis. And in that way, we felt like we were comparing more apples to apples. So we were comparing transferred acute MI patients to non-transferred acute MI patients, transferred sepsis patients to non-transferred sepsis patients, et cetera. And these primary diagnoses were based off of ICD-9 groupings that are used kind of commonly with Medicare data. The second way we did this was a statistical matching technique that I'm sure many of you are familiar with called propensity score analysis. And the way that this works is first we obtain what's called the propensity score, which is the probability of undergoing transfer for each patient. And you get that by sort of throwing all the variables that you have into the model. So you throw all the patient characteristics, all the hospital characteristics to get that particular patient's probability of undergoing transfer for each patient. And then you want to match each exposed or transferred patient to a control or non-transferred patients that had the same propensity score. And then we ran our analyses on the matched cohort, again, stratified by primary diagnosis. And in that way, we're trying to make the control group or the non-transferred group and the out of control group or the transferred group look more like each other. So for people that are familiar with propensity score analysis, what you first want to do is show in your table 1 how well you did with your matching. So to take you through just a couple of examples of how well we did with our matching, this kind of shows several of the characteristics before matching and after matching. So as you can see here, the HCC or that comorbidity risk score was much higher in the transfer group compared to the non-transfer group before matching, and after matching, they were much more similar. Hospital size, again, was much more dissimilar between the transfer group and non-transfer group compared to after matching. And then case mix index, the hospital's case mix index for the hospital that the patient initially presented to was much lower as expected in the transfer group compared to the non-transfer group before matching, and after matching looked much more similar. So in the interest of time, I'm just going to jump into the matched results to go over with you. So first looking at our the first outcomes that we looked at, the length of stay and cost, which again, we put together because they're very correlated. And across all diagnoses, what we saw was that transferred patients had both higher costs and longer length of stay compared to non-transferred patients. So just to give you a couple of examples for our top 3 primary diagnoses, acute MI, CHF, and arrhythmia, you can see that both cost and length of stay were nearly double in the transferred compared to the non-transferred group. Now, moving on to our mortality outcomes, this was really interesting. We saw a differential effect of transfer on both 3 and 30-day mortality, depending on the patient's primary diagnosis. And I'm going to take you through, we did forest plots to try to highlight this. And just to orient you, on the y-axis is the list of all the 15 diagnoses that we looked at. And then on the x-axis is the odds ratio. And you can see the dark line here is the odds ratio of 1. So anything that has the dot and the whiskers to the left of that odds ratio of 1 dark line indicates that transfer was associated with a lower odds of 3-day mortality. Anything where the dot and whiskers falls to the right of the line indicates that transfer is associated with a greater adjusted odds of 3-day mortality. And anything where the whiskers cross the line indicates there was no statistical significant finding. So what we see here is that among patients with primary diagnosis of acute MI, respiratory disease, sepsis, and stroke, transfer was associated with a lower adjusted odds of 3-day mortality. However, among patients with a primary diagnosis of esophageal gastrointestinal diseases, the GI diseases got cut off given the length of that, transfer was associated with a greater adjusted odds of 3-day mortality. And then there were no other statistically significant findings in the other diagnoses that we looked at. So moving on to 30-day mortality, we again found that among patients with primary diagnosis of acute MI and sepsis, transfer was associated with a lower adjusted odds of 30-day mortality. For the other 2 diagnoses, respiratory disease and stroke, those whiskers now cross the odds ratio of 1, so are no longer statistically significant. However, now, among patients with primary diagnoses of all these diagnoses listed, transfer was associated with a greater adjusted odds of 30-day mortality. So, putting these results together, one could argue that there is suggestion of mortality benefit to transfer among patients with a primary diagnosis of acute MI, respiratory disease, sepsis, and stroke. And there's also a suggestion of mortality risk to transfer of patients with these other primary diagnoses. Now, I want to take a step back here. This study is certainly subject to several limitations, and I think the biggest one is this possibility of unmeasured confounders. So as I mentioned at the beginning, we tried as hard as we could to adjust for this confounding of indication, to adjust for the fact that transfer patients are just inherently different than non-transfer patients. But we did that, using the statistical matching technique and stratifying by primary diagnosis. But there is still this possibility, right, of unmeasured confounders, that there's some other variable that's just not listed in our data set that sort of explains the results that we found. We would, however, have to assume that those unmeasured confounders had a differential effect based on the patient's primary diagnosis, given the different directionality in the mortality results that we saw. So in summary, we found that hospital transfer is associated with longer length of stay and greater cost among all patients with all the diagnoses that we evaluated. But again, we saw this differential impact on mortality based on the patient's primary diagnosis. So, as our study team, when we got these results, we were trying to hypothesize, why are we seeing this differential impact on mortality? And one theory that we came up with is that if you look at the patients or the diagnoses that are associated with a lower adjusted odds of mortality with transfer, these tend to be diagnoses that have kind of really explicit guidelines that direct their care, that direct their management. And this is different than the patients that are associated with, or the diagnoses that are associated with the greater odds of mortality that tend to be kind of more heterogeneous diagnoses with less explicit guidelines that direct their management. So potentially those patients are more prone to the risks of discontinuity of care. Now, this is just a hypothesis, right? This study did not answer that question. It just kind of gives us the results, and then we have to hypothesize why those results exist. So that leads me into the second part of the talk, which is let's evaluate what aspects of hospital transfer might contribute to these outcomes, or what are the what are the risky parts of the transfer process that contribute to quality? So the first part of how we wanted to do this was we wanted to evaluate some of the characteristics of the transfer process itself. And the way that we did this is with this study that we conducted on 25,000 patients that underwent transfer to our hospital at Brigham across all services. That I want to point out about this study. So the first is that to evaluate the transfer process characteristics themselves and to sort of tease out what are the aspects of the transfer process that contribute to some of the quality and safety outcomes that we see. We wanted solely to focus on transferred patients to be able to look at what aspects of the transfer process were contributed to poor outcomes. The second thing I wanted to mention is that this is obviously a site-specific study. So we focused on, a large number of patients that underwent transfer to our system, to our hospital. And the reason for that is because some of the transfer process characteristics that we wanted to look at are just not available yet in a national data set. So we really had to sort of focus on our site-specific data for this particular study. So the outcomes that we wanted to look at were, first of all, transfer to the ICU within 48 hours of arrival. And that's kind of a surrogate outcome, kind of harkening back to the case that I started with about sort of poor communication, poor triage at the time of transfer. So that's why we wanted to focus on that as one of our outcomes. And then we also wanted to look at 30-day mortality. And then the specific transfer process characteristics that we wanted to look at were, number one, weekend transfer versus weekday transfer. Number two, nighttime transfer versus daytime transfer. Both of those sort of alluding to this off-peak timing of transfer, kind of, again, similar to the case that I talked about at the start. The third one was this concept of admitting team busyness, which we defined as the total number of patient admissions and discharges completed by the admitting team on the day of patient transfer, kind of a marker of work compression by the admitting team. And then lastly, we wanted to look at the time delay between when the patient was accepted for transfer and when the patient actually arrived at the hospital. And the reason why we chose these characteristics were that these were all characteristics that were hypothesized or there were prior data to suggest that these might be associated with poor outcomes. And importantly, they were measurable within our database. So in the interest of time, I'm just going to, again, jump to the results. I'm happy to answer more questions about this at the end. But what we found was that nighttime transfer across all these 25,000 patients was associated with a 54% increased adjusted odds of ICU transfer and a 16% increased adjusted odds of 30-day mortality. Now, we also did some subgroup analyses that demonstrated among high acuity patients, these were patients that were transferred to high acuity services, nighttime transfer along with weekend transfer, as well as increased admission team busyness, again, that total number of admissions and discharges completed by the admitting team on the day of patient transfer, were all associated with an increased adjusted odds of 30-day mortality. So in summary, these results demonstrated that there was a suggestion of worse patient outcomes during off-peak timing of transfer. And there's also a suggestion of worse patient outcomes among these subset of high acuity patients when the admitting team is busy with a high number of patient admissions and discharges, or this concept of work compression on the day of patient transfer. Now, around this time in kind of my research trajectory, a lot of people at my hospital and my institution knew that I was interested and I was studying inter-hospital transfers. And I would just occasionally receive kind of venting emails out of the blue, people emailing me about their frustrations with inter-hospital transfers. So these are just kind of several emails that I got. One person said there was some confusion surrounding outside hospital direct admit transfer documentation. There was a paucity of information regarding the patient's presentation. There was some information that was lost in the surgery admission, and the patient's heparin drip and Plavix were accidentally discontinued. And, it kind of struck me that it was really, I think, important to try to understand the transfer process from the perspective of the stakeholders involved in that process. And that would be a really, I think, key way to kind of drill down to some of the most problematic aspects of the transfer process. So in the second part, we did just that. We wanted to get a concept of the experience of transfer from the key stakeholders that were involved in the process themselves. So to do this, we did a qualitative study where we wanted to explore, again, the transferred patients and involved care team members' experience or perspective with inter-hospital transfer. And we did this by conducting 36 semi-structured interviews of recently transferred patients, as well as their care team members, including the transferring physicians, their accepting attending physicians, and the admitting resident physician. And participants were asked about their experiences with hospital transfer using a semi-structured interview guide, which was then recorded and transcribed and analyzed. And we conducted thematic analysis that with an inductive approach using an a priori framework from pre-established domains. And in the interest of time, I'm going to kind of focus on just one of the domains that we focused on, which was communication during transfer. Now, following the study, one of your star faculty, Dr. Amy Yu, and colleagues have importantly added to this literature by performing a qualitative evaluation that now brings in the nursing perspective on inter-hospital transfer, which I think is also obviously very key to evaluating this topic. And so in this study, the investigators performed semi-structured interviews in focus groups of 21 inpatient floor level nurses to get their perspective on inter-hospital transfers. And so I'm going to present the results of sort of both of these studies and how they kind of mimicked each other in these next set of slides. So again, focusing on this kind of domain of communication during transfer, one thing that our study found was this concept of disorganized chains of communication. So transferring and accepting attending physicians kind of relayed that they were overall satisfied with the communication that happened about patients during the transfer process. The accepting or the admitting resident, however, tended to relay a dissatisfaction with a communication that they received that indicated that there was some communication breakdown that occurred within the hospital. But after there was sort of adequate communication between the transferring and accepting attending physicians, that information didn't necessarily trickle down to the admitting resident. So as one example, as this transferring physician said, "We just called the cardiac access nurse who picks up right away on phone calls, which is outstanding. We don't get shunted through a lot of different people. The process is very smooth." And as this accepting attending physician said, "I learned of this patient by an email from our cardiac access nurse arranging a transfer. She sends an email to all 4 of the attendings." However, as this admitting resident physician said, "The person who accepted her didn't leave any expect note, so it wasn't clear from my end what exactly had been going on and why the patient was being transferred or what the status of the patient was." So again, there was this sense of this disorganized chains of communication where, although there may have been appropriate communication at the attending to attending level, that information didn't necessarily trickle down to the admitting resident or the admitting clinician at the time that they needed to have that information to be able to admit the patient. Now, this concept was similar in Dr. Yu's study, where she found a similar perspective from the nursing perspective. So in this study, as this bedside nurse stated, "It's like I'm out of the loop. I don't know what's happening. I don't know what's going on. Sometimes I ask the patients, 'What did the doctor tell you?' Which is kind of odd. I should know because the doctors and nurses should be communicating." So I think collectively, these two sort of studies argue that there's this disorganized inter-hospital chains of communication at sort of multiple levels. So the second kind of concept that came out of our study was this sense of lack of advance notification. So as this admitting resident physician said, admitting this patient was actually a very challenging situation, mainly because we found out when she had arrived on this floor. So this is exactly sort of what happened in the case that I presented. The admitting resident had no prior knowledge of the patient's arrival until she got the page from the nurse saying that this patient had arrived. And again, this was sort of mimicked in the study that Dr. Yu conducted of bedside nurses. But again, this is from a slightly different perspective. Again, this is from the nursing perspective. So instead of being a lack of advance notification, it was more that lack of advance notification ultimately caused delays in finding the correct admitting team to come and actually evaluate the patient and to admit the patient. So as this bedside nurse said, Many of the nurses described paging different teams until the right provider was found. They're just like, okay, we'll try this person. And it's just like a never ending call him and call him. So it sort of all ties into it to each other. And then lastly, we found this concept of inconsistent health information exchange. So this was related to the same patient transfer. And as this transferring physician said, I think I didn't actually see the CD. I asked the coordinator to make the CD of his cardiac catheterization. I'm assuming that it went up with him, but I didn't actually check to see if it did. And then as the admitting resident physician said, the right heart cardiac catheterization information did not come either in the report or in the films. We had to track it down the next day. And again, this was mimicked in Dr. Yu's study on nursing perspectives, where this bedside nurse said, we don't know about what we know about the patient is always kind of up in the air. Sometimes what we get is very different than what we heard about. And sometimes what we get is exactly what we heard about. It's kind of a guessing game when the patient arrives, what we're actually going to be dealing with. So in summary, what we found, or what I'd say both of these studies found, and this is only sort of part of the results, again, in the interest of time, was that there was a differential satisfaction of communication where there was maybe appropriate attending to attending level communication, but that information didn't trickle down to the admitting clinician at the time that they needed that. And that was indicative of poor intra-hospital chains of communication. Again, that also pulled in the nursing perspective. We also found that there was a lack of advanced notification of the admitting resident physician, which was common, and that also related to delays in the nursing perspective and able to find the correct admitting team that led to a potential delay in care. And then finally, we found this concept of inconsistent health information exchange. Now, I wanted to just mention briefly about health information exchange, because I think this is going to be a key next step, which I'm going to get into later, particularly related to inter-hospital transfer. And I'm just going to try to go through a couple of these studies very briefly. But this was a study that I'd done with one of my mentees, where we looked at the impact of a shared electronic health record on duplicate imaging after hospital transfer. So this is more related a little bit to resource utilization rather than really kind of patient safety outcomes. But in this study, what we did was we looked at the number of duplicate imaging studies that were done on transferred patients sort of before and after implementation of a shared electronic health record. And what we found was after implementation decrease. In this other study that was conducted by Mike Usher and colleagues, what they did was evaluate health information exchange by conducting surveys of the hospitals in their area. And they found that hospitals that were participating in health information exchange were associated with a reduced diagnostic discordance of transferred patients, as well as reduced inpatient mortality. So I think some data to suggest that improved health information exchange both decreases healthcare utilization or resource utilization, as well as improves patient safety outcomes for transferred patients. So I've just thrown a lot of information and data at you, so I'm going to try to summarize this before we go on to our next steps. So what we have found is inter-hospital transfer is common, right? It's common amongst a variety of diagnoses, more common among certain diagnoses. There's unexplained variability in transfer rates nationally, which is suggestive of non-standard transfer practices. And there's suggestion of worse outcomes amongst select groups of patients. We also have found that there are some aspects of inter-hospital transfer that might contribute to worse outcomes, or there are some aspects that might contribute to the risks that we see with transfer patients. And that includes off-peak timing of transfer. And we've identified several vulnerabilities in the transfer process from the stakeholder perspective, including this concept of inter-hospital chains of communication and problematic aspects with that. Lack of advanced notification, as well as inconsistent health information exchange. So how do we use this knowledge that we've just kind of gleaned to improve the quality and safety of inter-hospital transfer? What are our next steps? So for the first kind of set of next steps, we know there's variability. We've demonstrated that there's variability in transfer practices. And I think, as I alluded to earlier in our talk, I think we're in this sort of new, kind of pandemic world where our management of interhospital transfer patients might differ. But I think we've seen sort of nationally, certainly locally, that our hospitals are at sort of at or are above capacity. And that leads us to sort of manage our interhospital transfer practices a bit differently. If our hospitals are already over capacity, we really have to figure out who's going to benefit the most from transfer. The pandemic has also led to this growth in kind of telehealth and technology. And I think that those have not necessarily been applied to the management of potential hospital transfer patients yet. So if we put all this together, I think the questions that come up in my mind are, how do we select the patients that are most appropriate for transfer? Who actually needs to be transferred? Could we potentially offer different alternatives? Could we offer a teleconsult for some patients? Are there other alternatives that might be safer and prevent some of the discontinuity of care for these patients? So to approach this, there are a couple of kind of first next steps that I'm hoping to achieve. So the first is I'm working with a collaborator at University of Chicago, where we're developing a survey that we're going to send to frontline clinicians who are responsible for accepting patients for transfer to the medical services, so general medicine, cardiology, oncology, ICU. And what we're asking these clinicians is, what are the top priorities that they currently consider when they're accepting patients for transfer? And what are the top priorities that maybe we should be considering when we're accepting patients for transfer? Because I think sometimes those things are different. And so that'll just kind of get a lay of the land of sort of, from the perspective of frontline clinicians, how we should be accepting patients for transfer. So next step number 2 is I just applied for grant funding in the fall. And actually, I was just chatting with some people earlier. I got a hopefully promising score. I have a call set up with the program officer next week. So we'll see if it ultimately gets funded. But this grant is proposing to use stakeholder input, including patients, transferring, and accepting clinicians, to first define what might be a potentially inappropriate transfer, or what transfers might be unnecessary in the sense of that sort of harm benefit ratio, where patients might be sort of subject to the risk of transfer without much benefit. So kind of using all these stakeholder perspectives to first kind of define what patients might be inappropriate for transfer, and then also to determine how best to predict those potentially inappropriate transfers, and then to develop interventions to prevent them. For example, with potentially providing them with safer alternatives, such as teleconsult, expedited outpatient follow-up, et cetera. So we'll see what comes with that. Keep your fingers crossed for me. For next step number 2, as we talked about, we've now identified several modifiable risks in the transfer process. So these concepts of intra-hospital chains of communication, lack of advanced notification, inconsistent health information exchange. So how can we address that? Well, first step is I'm currently conducting a CRICO-funded research study where within our hospital system, we've been working with a stakeholder working group where we first kind of did a whole process map, identified sort of the pain points, and tried to figure out the necessary pieces of information that an admitting clinician sort of needs at their fingertips, as well as sort of streamlining, getting them information on where to find the more detailed information. And so sort of to summarize, we have implemented a standardized accept note that's completed by our access center that goes into the patient's chart at the time that the patient is accepted for transfer. And then we are also working on improving advanced notification of the accepting team of the pending interhospital transfer patient. A side caveat is that improvement in the notification piece is proving harder than initially anticipated because it involves a whole kind of epic fix, which is just more complicated than we thought it would be, as happens with a lot of these interventional studies. So happy to answer questions about that at the end. But ultimately, we're implementing at least the accept note. We're trying to get this notification piece off the ground, and we're measuring the impact of those on patient outcomes. And then to address the inconsistent health information exchange piece, I applied for another grant that I haven't gotten the score of yet, but the goal of this grant is to design and implement a health information exchange platform. Again, using input from both the transferring and accepting providers to see sort of what information is both feasible and useful for people. We implement that and measure the impact of that on patient outcomes. So in conclusion, we've done a lot of work on evaluating the quality and safety of transfer. We're trying to do some interventional work to improve some of these care processes. We still have a long way to go, but I think at a minimum, the work that we've done to date has helped to guide us in terms of next steps that we can focus on as we continue this work. And I think, importantly, our goal is to improve this care process, this care transition for all the stakeholders involved. So certainly we want to improve the quality and the safety of this process for our patients, but we also want to do it in such a way that it's not going to add, be burdensome, and will also sort of improve the work that we do as clinicians across the board. So with that, I want to end my talk. I want to thank all of my collaborators. Certainly research is a team effort. And I worked with many, I've been fortunate to work with many collaborators throughout all of this work, and I will open it up to questions.
Dr. Mueller, thank you very much. We have a lot of questions. Thank you for giving Dr. Yu such a nice shout out as well. It's always good to see one of our former chiefs get recognized like that.
Yeah.
I'll start with Dr. Anstead, who is one of our quality and safety leaders here at Colorado, who I'm sure you know. He says that thank you for the important work that you've done. In your national samples, did you identify variability between similar hospitals? And in other words, did you find that some similar hospitals perform better than others that might indicate more selective IHT practices?
Yeah, we looked at variability more in transfer rates between similar hospitals. In terms of outcomes, we didn't specifically drill down to looking at outcomes like mortality outcomes and whatnot between, transfers of patients between, just kind of the tertiary care facilities compared to the, the sort of rural care hospitals. Part of it is that, as expected, the majority of patients that undergo transfer are coming from smaller rural hospitals. So within that, it's hard to drill down further in terms of the hospital characteristics. But I think, one thing that we had considered that we hadn't pursued yet, I think just out of time and budget, is looking at outlier hospitals. So the hospitals that have really, high outliers on both ends. In terms of quality and safety outcomes, and then doing a deeper dive into those hospitals to try to evaluate sort of transfer practice differences in those hospitals. I think that would be a great study.
Yeah, thank you. There's I think a similar question that has to do with some of the study design that you talked about in your earlier work. When you talk about matching for propensity score, are you matching patients that ultimately stayed at outlying hospitals and therefore these are patients who would have been transferred or not, but were cared for at a community hospital? Or are those propensity scores matched to people that were in the Harvard system who had sort of spent, every minute within your hospital?
Yeah, no, the propensity score matching was using Medicare data. So that was across, all the hospitals. So, and then it was Medicare data matched with AHA data. So I worked with Ashish Jha, who does a lot of sort of health policy stuff using those two data sets matched together. And so I worked with his programmer and got access to the data sort of through him to be able to, so AHA data has sort of national, kind of hospital representative data matched with the Medicare patients. So the propensity, we were matching essentially a transferred patients, and each transferred patient was matched to a non-transferred patient that had that same propensity score, the same propensity or probability of transfer, but one did get transferred, one didn't get transferred. If that makes sense.
And those were compared at hospitals of similar size, or was it only by their disease characteristics?
It was matched based on propensity score. So to generate the propensity score, all the hospital characteristics and the patient characteristics went into the model. And so effectively, yes, but it was mainly just based on the propensity score.
Got it. That's great. I think that actually took care of 3 or 4 questions. So that was great. Appreciate that. There's a question from our house staff who are obviously on the front lines of a lot of this, as yours are, which is that we all agree that having no information for an outside hospital transfer is really difficult to deal with. That being said, what do you think is the most practical and then an optimal form of communication when you're dealing with these transferring patients? Is it direct communication, brief accept notes, warm handoffs? What would your ideal state be?
Yeah, I know. And I've talked with our residents about this a lot. I know a lot of the residents would prefer a warm handoff because I think the nurses get that within our institution. I think that happens at a lot of hospitals. I think there's this balance between like ideal modes of communication and effective modes of communication that are also feasible. And so I've had a lot of discussions with our access center and sort of powers that be to see if we can do a warm handoff. I think the difficulty with that is, and I'm sure this is true at other hospitals, our general medicine in particular, but even our oncology and cardiology services are so big that a patient is accepted to those services without necessarily knowing exactly which team that patient is going to be going to. It sort of depends on what bed they get and when they arrive, et cetera. And so to be able to coordinate that warm handoff for the admitting like resident or the admitting PA or the admitting NP or the admitting attending is difficult because we don't necessarily know what team that patient is going to. And then if they're might be accepted, but they actually are leaving the hospital maybe 5 hours later when there's a different clinician at the outside hospital, so there's a lot of coordinating processes. So, with our stakeholder working group that I've been working with the past 2 years, we've been working on developing this accept note, which we put into Epic, which has kind of more the bare bones of clinical information about the patient. We actually are using the iPass format for our accept note. And then at the bottom, we have sort of a templated thing that directs our clinicians as to where to get the more detailed information, like the transfer records that come with the patient, which luckily are now sort of generally electronic, although it still is sort of a hodgepodge of whatever gets sort of e-faxed over and everything. And so it does take a little bit of chart biopsy, but at least because another sort of thing that came up with our stakeholder working group is sometimes, especially with the changeover of residents that happen every year, people don't necessarily know where to look within Epic to find the transfer documents. So having just that information kind of imprinted at the bottom of the templated accept note that we have helps direct people to more detailed information. The other thing that I have to say that's been helpful, although hasn't solved a lot of our issues, is just the improvements in the kind of care everywhere through Epic. We have Epic at our hospital, and so you're able to access some of the some of the lab data and sort of imaging reports and whatnot through that, just to be able to get a sense of the trend. With this other grant that we submitted, and we'll see if that gets funded, we're still trying to improve on that aspect to consolidate things in a little bit more of a structured manner for the health information exchange piece, which I think would be helpful.
Yeah, I think we've seen that too, which is it doesn't obviously replace communication, but it's nice to know something more about the patient than you used to get otherwise.
Exactly. Yeah.
Certainly. Question about responsibility and training for these efforts. This is another one from our house staff, which is, residents do this, but they're not necessarily trained in it, or at least not at every institution in the country. What do you think is the role for resident education in learning to be a part of this process?
You mean in terms of accepting patients for transfer?
Accepting, that's right.
So this is a conversation that just came up recently with another talk that I did, and I think this is key. I think a lot of the difficulty is that none of these processes are standard right now in terms of who we should be accepting, how we should be determining appropriateness for acceptance. Even within our own hospital systems, similarly, it's an attending responsibility. But in various places, it's either an attending or a resident responsibility in terms of accepting patients for transfer. But I have yet to kind of come across an institution that does actually training for this. And I think part of it is that we don't really have the data to help guide best practices in terms of who we should be accepting for transfer. So I think that's a lot of the work that I'm trying to focus on in terms of next steps. Is trying to identify what patients do versus do not benefit from transfer, and then we can sort of convert that into training guidelines, standardized guidelines to help guide people with that process. But yeah, I see that in the future. I do.
Yeah, I think I do as well. What do you think about the nursing communication piece? And I think this comes from people who know your work with Dr. Yu as well. Who in your world should be ultimately responsible for this? So there are many people who could communicate with the nurse. There are very few who do, but in your system, if you could sort of wave the magic wand, who would you have be responsible for that?
I'd like to ask a clarifying question about that. In terms of, are you talking about the nurse accepting the patient for transfer, or within the hospital once the patient arrives for transfer?
I think it is when the patient arrives for transfer, although I'm reading the questions. I believe it's the nurse who's going to receive that patient.
Yeah, so I think, in my opinion, I think the key factor of that is the advanced notification piece at the admitting clinician level. So this happens at our hospital as well, where the nurse is playing like tag team, like paging this person, paging this person, paging this person. They're paging somebody who's like home for the night, who never signed out their pager, and then nobody calls back. And that's a really difficult position for the bedside nurse who's trying to take care of this patient. We've had safety reports that have been filed related to that because the patient has a delay in getting their pain medication or some other medication that they need because they can't find who the admitting clinician is. So I think if we look more upstream, if we look more proximally and try to improve the advanced notification of the admitting clinician, that will certainly help the nursing communication piece. And then it would be the responsibility of the admitting clinician communicating with the nurse. So our proposed fix that is being delayed right now is essentially, we have the team list on Epic. And if we can get at the time that the patient is accepted for transfer, even before they arrive, we want to add that patient to the team list that they're going to go to. And it is doable in theory. I guess in practice, the back end of Epic, it's difficult to assign a patient to a team list when the patient isn't physically in the hospital yet, but it's doable. It's just, I think, with these COVID surges and whatnot, there have been other Epic priorities that have risen up. So we're still on their list to get that happened, or to get that, implemented. And so, we're hopeful that will go forward. And I think that would, because people, residents and everybody's on their team list all the time to, access their patients to provide patient care. And so if that patient pops up on the team list, then you can the admitting clinician can proactively start reading the accept note, accessing the transfer documentation, et cetera, to learn about the patient. So then when the patient arrives, they'll know it because they'll know about the patient. So I think we focus, that's my take on it, is if we focus on the upstream advanced notification piece, that'll solve a lot of those issues.
Yeah, that makes sense. It makes really good sense. And I've been in that Epic line before. So
yeah.
I may still be in that Epic line for something. I have one last question from the audience, although there are many more, and then I want to turn it over to Dr. Chopra. Can you talk about, we think a lot about healthcare disparities, obviously, and can you talk about the effects of race, ethnicity, gender on these processes that you're trying to improve? Do we know that this is also an effect here?
Absolutely. So one of my research mentee, Evan Shannon, who sadly left us at Brigham and went out to LA for a faculty position, but he is a fantastic researcher and studied specifically that topic, so racial and ethnic disparities in inter-hospital transfer, and did find that there are not surprisingly, like as we see in other aspects of healthcare, that there are racial and ethnic disparities in inter-hospital transfer, where Black and Latinx patients, depending on sort of which data we looked at, had lower rates of hospital transfer. And interestingly, women also had lower rates of inter-hospital transfer, which has not been focused on as much, but it was sort of like an incidental finding that Evan found with his research on that topic. So I think that more needs to be done sort of proactively. I think Evan's done a lot of work. There's a lot of disparities in sort of I think across the board to access to inpatient specialty services. Like there was a study done at our hospital where we found that minority patients were less likely, when admitted with heart failure, were less likely to be admitted to the cardiology service, which has actually made the local news because some of the investigators on that topic have been targeted, unfortunately, by sort of radical right groups. But I think it sort of runs the gamut. And I think inter-hospital transfer fits within that realm of access to specialty inpatient care. And so I think we need to sort of address that kind of on that global front, in terms of access, or in terms of addressing disparities in access to inpatient specialty care.
That's great. Yeah, I'm glad to hear that work is happening. And we did see those attacks here as well. And I know the ATS and a lot of our groups spoke out against them. So I'm sorry that those are happening. Dr. Chopra, can I turn it over to you for the last question?
Yeah, Stephanie, first, thank you for a great talk. I was taking notes the whole time, and I have like 8 questions, but I'm only ask you one because we're at time. my dad was recently transferred from a hospital in India, and India doesn't have a very advanced EMR system. So all of his records were in a bag, and he walked in with the bag and said, here's my records.
Yeah.
And I talked to him about it, and he basically was like, the doctors were surprised when I showed up. They didn't know why I was there. They said, where are your records? And I gave him my records. And my question for you is, have we ever done qualitative work with patients when they're getting transferred to understand how they appreciate the process?
Yeah, so I did that as part of the qualitative study that I presented, where we talked to patients as well as their care team members. And interestingly, because a lot of my focus on that, the semi-structured interview guide was focused on communication during hospital transfer. I have to say, and I didn't present this just in the interest of time, but patients just blindly accept that information is being transferred adequately. So they just have full confidence that the doctors at the receiving hospital know what they need to know about them. So they really had no concerns about that aspect of transfer. The biggest concerns that the patients brought up as part of the study was more the physical aspects of the transfer. Issues related to the ambulance ride, the length of the ambulance ride, lack of medication during the sort of physical transfer, kind of arriving, being close to the nurse's station. They liked their other room better. Like some of those physical, which is understandable. I think those of us that have had experience on the patient side of things, like those sort of comforts or whatnot, is what's first and foremost. But yeah, sort of across the board, all the patients that I interviewed had no concerns about the communication between their providers.
If only they knew, right, Steph?
Yeah, I know.
Well, Dr. Mueller, it is 1 o'clock, so I want to be respectful of your time, but thank you again for giving this talk and for taking time to, have a conversation with us and answer questions, and for coming to Colorado. I know you are here both physically, but also virtually, at least for this talk. So thank you very much for your time.
Thank you so much for having me. It's been a pleasure. And feel free to reach out to me over email if there's any other questions that anybody wants to bring up.
Will do. Thanks.
Thanks all.